brief them what are the prevention that needs to be done. So he'll be enlightening us today with them. Over to Dr.
I think Dr. Neetu's connection is a bit weak. I request Dr. Mandeep, sir, to please start with the session. I request you to please share your screen.
Yeah, good afternoon, everybody, and thank you for the invite and the opportunity. Let me start by first just trying and sharing my screen, and let's hope you can all visualize it. Is it visible to everybody now?
Yeah.
Yes.
Yeah. Oh, good. Let me get it to full screen. Is it in full screen for everybody now, I guess?
Yes, sir.
Yeah. So if you allow me, I think I can start now.
Yes, sir. Please go ahead.
Okay, thank you. Thank you so much. So as Dr. Neetu Kamra has introduced me, I'm Dr. Mandeep Singh Virdi, and I have been practicing and teaching pediatric dentistry almost since 99. Yeah, 99 I finished my master's, and ever since I've been into practice of pediatric dentistry. Initially, I started off with starting my pediatric dentistry at Jaipur Golden Hospital. And after that, I was working for quite some time at Jaipur Golden, and then I was working at various other hospitals, including Bhagat Hospital, where basically I was doing a lot of work with children under general anesthesia. But the main objective of today's presentation is going to be, I'm just gonna, although I'm sure all of us, are seeing children with oral health problems every day. And the basic thing is, any child with any oral problem or any dental problem, the first person most likely is likely to approach is going to be a pediatrician or physician, if at all he's seeing a physician. So it becomes very important that we are aware with the common issues which the children have, and many a times I'm sure you must be aware about all the questions that parents come about, and I'll just go through those things which commonly pediatricians refer me the patients with. And so I will just try to enlighten everybody about those concepts so that maybe you are able to better handle those situations at your end, and maybe identify the patients which need to be sent to a pediatrician. So I'll just start with my first slide. So role of a pediatrician or a physician in oral health of child. So as I've already mentioned that, all the children as they are born, because of their vaccination for their daily needs, of their health needs, they are always visiting their pediatrician and physician. And obviously, it's pretty common to understand, easy to understand that if a child develops an oral health problem, or even if it is a normal, developmental landmark, many times the parents are not able to identify if it's a normal thing or if it is a health issue. So they will obviously always, first of all, approach their pediatrician, which is the right thing to do. And in that cases, it becomes important that the pediatrician or the physician who's going to attend the child is able to guide the child properly. So I would just like to introduce a concept. Maybe many of you are aware about the concept, maybe many are not. So I would just take 2 minutes to introduce the concept of a dental home. Dental home, although not very common in our country, but in Western countries, dental home is sort of a concept wherein child is introduced to a set of people, group of people, or a group of locations wherein along with his general health, his oral health is also taken care for. The whole idea is that the child already has somebody to take care of his oral health even before some dental health develops. So, if any dental health issue develops. So what happens is, as we may be very aware that once the child has a dental problem, and most of the times parents will be little late to notice it, and sometimes it takes a little longer to send for the referral. By the time child comes to a pediatrician or a pediatric dentist or to a general dentist, most of the times the situation is such that it becomes a little difficult to handle the child, in the first go, because the patient has directly come for the emergency. So if we introduce this concept of dental home, and if we understand what is the role of the pediatrician or the attending physician, or what all he has to look for or how he has to help the child to help the oral health, it will be good. So these 4 points, which are very commonly seen and are being followed throughout the Western world, and also in our department to an extent at my colleges: early education, screening and referral, preventive care, and collaboration. So early education, main thing which I understand is, as I've already mentioned a couple of times, that the first person or the first doctor the child will encounter is a pediatrician, and many a times a gynecologist, because the mother will be going to the gynecologist. So the gynecologist and the pediatrician can, guide the parents, the mother or the caretaker, whoever is the caretaker, in the direction wherein we introduce the concept of oral health even before a problem develops. For a very simple example, many parents, they reach the pediatric dentist asking, when should we start brushing? When should we start brushing? Or where some very basic questions like, the teeth are erupting a little late, what should we do about it? Or, dental caries which are not detected early, or the preventive steps which could have been given to prevent those conditions. Many a times as a pediatrician or as a attending physician, we may not be able to decide or judge when when is it early enough to send the patient to the expert. So I'm not going into detail of any condition. I have just refreshed my memory of about last 20 years of practicing pediatric dentistry, and just thought, what are the conditions for which generally children are coming to me? So what I have done is, I have taken one generic picture of all those conditions, and I will just give very small and very basic inputs, wherein we can identify those conditions and guide the patients accordingly. So obviously, the very first issue for which many pediatric patients, they come to the physician or the pediatrician, is the teething issues, because teething is a very important developmental landmark, and it's a very visible and a very obvious landmark, and most of the parents are really looking forward ki, okay, बच्चे का दांत निकलने वाला है, and it is generally expected कि okay, 6 months में the first teeth should start showing, things like that. So many a times also many conditions are associated. What are the conditions which are to be expected in parallel to this teething? As we all, as physicians, as pediatricians, as gynecologists, and as pediatric dentists, understand that there are very few conditions which can be directly associated with eruption of teeth. That too, what generally happens is, teeth which are small in size, the first teeth which erupt, especially the lower anterior, primary anterior milk teeth or incisors, generally they don't cause much of an issue, because they're very sharp teeth and they're able to cut through the gum. So, at best, drooling or little bit of swollen gum, those things are associated and can be expected. But getting fever, getting irregularity in the bowel movement, those things are not really directly related to any of these eruptions. So, if at all a child is complaining of these things, we should try and look in for the associated factor. Obviously, if a child is teething, he would be having irritation in his gums, and to soothe it, the child will put something into the mouth, and that in turn may lead to some stomach upset or something like that. So directly, teeth, especially at least anterior small teeth, they are not supposed to cause any trouble when they erupt. So I would just like to talk about another issue which the parents are very concerned is delayed eruption. Delayed eruption, normally it's a thing ki by 6 months, parents are expecting the teeth should erupt. But in my experience of practicing pediatric dentistry, obviously I'll know only about the patients which are referred to me, and obviously they will be referred to me only once the eruption is delayed. My experience tells me till first birthday, unless there is some other developmental delay, which of course the pediatricians are already taking care and looking for, we should not get much bothered, and probably we should just tell the parents to wait till first birthday. And till first birthday of the child, if none of the teeth are visible in the oral cavity, then yes, the child should be referred to a dentist or a pediatric dentist, whoever is available at the earliest, and probably they can look into the factors, because I am already assuming that, because I'm talking to all pediatricians and physicians, all the medical aspects are already taken care of, and I need not go into them. Of course, we do understand that premature birth and low birth weight, which is again maybe caused by premature birth, in these cases, the general development is slightly delayed and teeth eruption is also delayed. So to compensate for that, rather than 6 months, we should start getting bothered only by the first birthday, right? So that is a thing. Another thing which, many a times the child will come to me. Can you see my cursor, please? Can you see my, is my cursor visible on the first slide?
It is visible.
Okay, thank you. So another thing which, many a times which we are, brought to our notice, or something is condition which is the presence of natal teeth. Normally, as a pediatrician, very few children really need too much attention with the natal teeth. Only reason or only time children may need some help with the natal teeth is when there is a problem in the feeding. And now, many times in my experience, what I have seen is, if we just let the tooth be around for some more days, most of the times the mother and the child realize that if they hurt each other, then the child does not get the milk and child learns to feed with the tooth on. But in case there's an issue and yes, the mother probably is not able to, feed the child, then of course we have to consider removing the primary tooth, the first primary tooth. Only concern is natal teeth sometimes are supernumerary. In those cases, it's not an issue, but we must make our parents aware, our patients' parents aware, or the caretaker aware, that once we are removing this tooth, the natal tooth, the probability of this tooth coming again is very less. And for the next at least 6 years, 5.5, 6 years, 7 years, sometimes the child may not have this tooth. So, the decision, of course, if it is needed to be removed, we remove it. But this information we must give the child, a parent, that for next 6 years, the child is not going to have any tooth if it is not a supernumerary. So those are the considerations while, sending it for extraction, or trying to make the mother understand, or helping the reshaping of the tooth or covering of the tooth to make the feeding a little bit more easier. The other common concern, which many a times, and it looks visually looks a bit dangerous. It is nothing. It is just an eruption, hematoma. It's just this bluish enlargement. Although in this slide, it seems to be associated with anterior teeth. But most of the time, and this particular slide, it is being associated with permanent incisors. Many a time, you may see similar situation in children with primary molars. So you can imagine that before the third birthday of the child, this bluish type, growth coming unilaterally on one side, on the upper arch or the lower arch, in the back teeth on one side, both the sides, is a possibility. Have to do much about it. Unless it gets infected, we can just wait for the tooth to just erupt through it. And if the parents are too concerned, and if they feel, then of course we can, incise it and let the tooth just come through it. Only concern is that it should not get infected. In most of the cases, if little hygiene methods are taken care of, this does not get infected. Another very common condition, and in fact, according to the latest literature and Indian literature, every 6 out of 10 or 5 out of 10 children will develop dental caries. Now, the problem is, as a pediatric dentist and practicing for so many, almost 2 decades in city of Delhi and Bahadurgarh, most of the cases I get when the child, I'm sure you're able to see my cursor, I generally get patients when they're at least in this stage, that is the damaged caries stage, or when they are in a deep lesion stage. I hope you can appreciate on the slide, and many a times when it is in a traumatic stage wherein the tooth is so damaged that even with a mild injury to mild impact on the tooth is just lost. So, the problem is when the child is coming in the damaged stage, the deep lesion or traumatic stage, generally the treatment which is required, many a times a small child who is maybe in his 4th birthday, before his 4th birthday or before his 3rd birthday, he is maybe not in a position to take so much treatment in the one go sitting on the dental chair. It's not that all the children cannot be treated, but many of them cannot be treated. And then we have to go in for behavior management using pharmacological means like sedation, anesthesia and all. But the whole purpose of showing the slides to this, the pediatricians and the physicians attending the children early, is that if we can identify the tooth in this stage, which is a very critical stage, which is the initial, and please concentrate on the word reversible stage. And I am sure all the children, most of the times, for their vaccination or for their throat infection or any other common conditions, are coming to us. They are coming to us. And if we could just dry the tooth a bit, just hold a little bit of cotton swab, clear it up, we will be able to see this whitishness. I hope you are able to appreciate my cursor. This whitishness you will be able to see. The beauty of this condition or this situation is that if we simply somehow instill oral hygiene habits into this child, change his dieting pattern a little, and if at all need be, take the help of some dentist or pediatric dentist or even a general dentist to apply fluoride or other preventive measures, this stage will either get arrested here, or at least it will not go into this stage, and then it will not go into this stage. I want to emphasize, probably most of you know, beyond this stage, damaged caries stage, it is totally irreversible because we have already lost the organic content of the tooth. And whatever you do, unless you physically prepare and repair this tooth, you're not going to get it back into the first stage. So my request or the takeaway from today's presentation is, as many patients as we can identify in this stage and send it to even a general dentist, we are going to do a real big favor and a good service to the child. Other conditions with which, many a times in which patients do get referred to at least my practice or to my department, is when the children, develop condition like cellulitis or pus, pustule or paralysis, whatever you want to call it. Only thing is, we have to identify or we have to appreciate the fact, whatever systemic antibiotics we may give, this condition is not manageable. This condition, yes, it may get managed for a week, 10 days, 15 days, but I can bet the child is going to come back in this stage, maybe in this side or maybe on the opposite. We have to remember, we have by 3rd birthday 20 teeth in the mouth. Caries lesions are all progressive, I have already informed. And once it reaches the traumatic stage, if we remember from the last slide, the child is going to have infection in the periapical region. Bone is very soft. Infection is going to penetrate through the gingival tissue and show it as a pus. This is still okay, manageable, not very scary. This is when the child's immunity is somewhat allowing the infection to spread within the phases or planes because of the enzymes of infections, and rather than an abscess or small abscess in this region, a child develops a generalized cellulitis. Always remember, cellulitis in the lower region, submandibular, I'm sure we are all aware about it, bilaterally is a very deadly situation. And the problem here is, if a child has a cellulitis or a damaged tooth which can cause cellulitis in one side, there are almost 70% chances by literature that it can happen on the opposite side also, because it is the same mouth, it is the same diet, it is the same oral hygiene. And if we manage one side, and before the swelling goes off in the lower mandibular region and the child develops the swelling in the other region, it's, it can be, a dangerous situation. Child may need to be hospitalized because he or she may have difficulty in breathing. So that were the conditions. There are other conditions for which many a times the parents will come, and we may need, sort of a specialist intervention, is malocclusion. Especially my concern here is the developing malocclusion. So malocclusion, I have hundreds and thousands of slides available. So I thought, let's show a good occlusion. So if you're looking at something like this, you're okay. And these spaces are very normal in primary dentition. These spaces are very normal. These are okay. But if we see a tooth which is positioned sort of overlapping, crooked, rotated, or the arch not overlapping, just imagine the upper arch to be like a skirt over the lower arch. If something like this is not happening, that means the child needs to be seen by a dentist, and it will be a good service to the child, because at early stage, that is before the growth spurts are before the growth spurts have happened, we can really use that growth to our advantage, and many a time the child can develop a occlusion and a facial profile, a beautiful facial and an ideal facial profile, just by very minimal interceptive, but provided we are able to use at least 1 or 2 growth spurts. So I'm looking at children who should be referred to a dentist as early as 8. 8 is the ideal. Earlier, also no harm. Later, as it becomes 10, 11, in case of girls, it keeps on becoming difficult to manage the situation. Another problem which many a times, parents would notice is bruxism. When the child is grinding their teeth, and I'm sure we all know about the medical reasons which can cause bruxism. So let's discuss 1 or 2 reasons which are local and which are not generally medical. So of course, let's not discuss stress, anxiety, those things we are all aware that children can develop bruxism, or they may brux or grind their teeth in the night, and parents would generally typically complain about noise, bacha ghode dauda raha hai. Like in my college, where I have my department there in Haryana, they would say bacha ghode dauda raha ji raat ko, to matlab wo awaaz nikal raha hai. And of course, in our cities, they would say that the child is making some noise if somebody notices during the sleep. Now, during about 6, 7, 8 years of age, 5.5, 6, 7, I would say, if that problem was not pre-existing, and if we cannot look into a medical reason, and by 6, 7 years, we already know the child, we already know the family. It seems to be a fairly stable family, and there is no much cause for stress, at least perceivable. Then it can be considered normal. Why? Because the permanent molars would be erupting around 6, and permanent molars, they are much bigger as compared to the primary teeth, almost 1.75 times bigger than the next biggest primary tooth. So we all know that the teeth are supported by soft tissue in the hard bone, so they need to be adjusted. So sometimes the child may be indulging in some amount of clenching or biting during the night or the day, involuntarily, to just adjust those teeth. So besides that, if there is an issue, of course, the child needs to be referred to a dentist. One simple way to understand is, if you can just appreciate my cursor on the left top slide, if you can see, the size of the teeth have worn off. I mean, the size of teeth has reduced. The teeth are never square generally, they are oblong. So if they're not oblong and if they appear squarish, I mean, there's a long-term trouble, and then of course you need to immediately show the child to some dentist. Of course, I'm not getting into the dental management. That will be too much. Let's go to the next issue. Another thing for which many a times parents or children do come to our, to the physician or to the pediatrician, is the child indulging in oral habits, oral habits or deleterious oral habits. I mean, those habits which will have sort of unwanted, undesirable effect on the development of the child. On the left slide, please, all these slides are generic, none of them are mine, so I must tell you that. So anyway, because our slides seem to be more scary, and I mean, for a casual listening, I don't want to use them. So anyway, so these are more generic. So this child, of course, is indulging in thumb sucking in oral stage. This can be normal, but if the child is continuing well into his school years, I mean, even starting of his formal school years, the child needs some attention. And main thing is thumb sucking, because there is an actual extra physical disturbance or interruption between the jaws. Then of course, it has maximum deleterious effect, maximum unwanted harmful effect on the shape and growth of the face. And of course, the child is going to go through the growth spurts. And with this habit, I mean, child indulging in the habit, we are looking at a very high speed, unwanted shape and size of the face. Of course, nowadays most of the boys are having beards, so many a times it gets camouflaged, but that is no reason not to go in for the treatment or intervention. Of course, mouth breathing, many children, parents notice, they don't notice, but of course, as a physician or a pediatrician, when we look at the lips, we can make out that the child is breathing from the mouth, and of course, after the basic ENT exam, and if the child is okay to breathe from the nose, and if the child is still not breathing through the nose, and probably he or she needs to be trained to be breathing from nose, because after we do the correction, sometimes the child is just not aware, he needs to be trained. So for that, again, we would need the help of a dentist. So those children, after the ENT clearance is achieved, taken, then we can always send these kids for the training. Cold sore, chancre sores, of course, many a times children will come with at least chancre sores, because children keep on getting this, especially we all are aware when the child is having some antibiotics. Sometimes if there is some gastric problem, there's a basic vitamin B deficiency, so they keep on getting this, and once they get this, they just keep on reappearing. So I'm talking about the blisters which you get within the oral cavity. Normal, they don't have any viral implication, they are not transmissible, they are totally different from cold sores. So we should identify like that. And normally once the ulcers or sores, they heal within, say, 2 weeks time, we can just give them sort of a supportive therapy. And if it is repeating too much, and if no medical reason or systemic reason can be attributed, then of course we can have a look done by the pediatric dentist or dentist to look for local factors which may be causing them. Of course, the cold sore, they are called by HS, all those things. I'm not going into detail. We can manage them, no issue. Another thing for which the parents will bring the child to a pediatrician or a physician, of course, they will bring when the child has dental trauma. Of course, the right side, this is again textbook picture. It is not a patient picture. And this is very obvious. And most of the parents will bring the child to the pediatrician or physician, maybe to a dentist. But what I want to concentrate is on the left side or the first slide. Many a times the child, when he is in school, he or she may be indulging in some physical sport or contact sport, although less, but yes, some of them do. It will lead to, you know, although this is too much of a fracture, the fracture may be less than this. So my concern here is that it may go unnoticed. And main issue here is, we are talking about a young adult, a child who is, say, this tooth normally would erupt around 8 or 9 years of age, and say he gets an injury around 9.5, 10, fallen from a cycle, just fell down, indulging in some contact sport or some normal football or something like that, cricket. The thing is, the pulp horn here inside is very big. So even though it may not seem very devastating, it may not seem very big, it may be unnoticeable to the child or the parent, and most of the time the child may not report to the parent if it's a minor problem, or he or she may not notice also. But the thing is, once the pulp is large and we have to understand the child is eating, drinking multiple times, brushing his teeth, the chance is dentin, the second layer, is sort of porous, or it will allow the ingress of some fluids, water, drink, whatever food, into the pulp, and eventually the pulp will inflame, and actually the child can report with a big swelling, cellulitis in the infraorbital region, maybe at the age of 10, 11, 12, 13, and we are all aware around the nose, below the nose, above the lip is the dangerous area of the face. This infection can be quite, it needs attention. And main thing here is, many a times we will not be aware of the cause. So the point I want to drive home is that if you notice while normal examination any cracked or fractured tooth, please do advise the patient to look up a dentist. Now, I have mostly shared the conditions which I feel children come with problems to the doctors or to the pediatricians. Of course, we'll discuss if there are any more you want to after we finish the slides. I would just like to emphasize, on my first couple of slides, which was talking about dental home. So although I mentioned there that we have to sort of institute the idea of maintaining oral hygiene. So the whole idea is, most of us may be even aware of it. Probably sometimes we don't have the time, the indulgence of time to tell the child. But if we could have very small posters or maybe a small booklet wherein, depending upon the age of the child, we can tell the parents or the caretaker how to clean the teeth. And if you would just appreciate, I've started my first slide with cleaning the gums, wherein the teeth have not even erupted. Although we have the specialized finger brushes available, but even if the mother or the caretaker just takes some thin cloth, even a gauze piece, even if the gauze piece is not available, a clean kerchief, just rinse it with water and just wipe while the child is just about to sleep or little drowsy. The child from the very beginning, the infant from the very beginning will have a feel for a clean mouth, because microorganisms, microflora, and the resulting plaque, they multiply and grow layer upon layer. And of course, the microflora biota keeps on changing as the child develops, the teeth erupt. But if we have already instituted the idea of a clean mouth, the child will appreciate it and probably maintain his health as and when, his teeth erupt. So many a times, patients may be asking you कि भाई brush कब करना है? Brush करना है जब से दांत erupt हो जाए from the first day. Of course, brushing is not a task to be left I mean, it's such an important task. It should not be left as a responsibility of the child. And I am talking right up to 8, 9, or 10 years. I'm not insisting that we brush every time, but technically speaking, till almost 8 years, even with very good training, unless specialized power brushes, which many of the parents may not indulge in, the child may not be by himself or herself able to clean his teeth properly. So I'm not insisting that all the brushing needs to be done by the parents, but at least one brushing before the night, before the child goes to bed, should be, if not done by parents, at least be closely supervised. And of course, with each child, it's different. Maybe some children after some time will need supervision less frequently, but I still believe it's worth the effort. So, of course, I'm sure most of you will be knowing about the products which are available. I am not with Colgate company. I've chosen the Colgate company materials, products, because they're comparatively less expensive. And this is one product line which starts from 0 and continues right up to 9. And after that, children can use the normal brush, the normal paste I'm talking about. So basically, right from the beginning, 6 months, 8 months, as and when the teeth start erupting, we can start cleaning the teeth with paste. Only thing is, the first one, the 0 to 2 years, it does not contain fluoride. These particular products, 2 to 5, 6 to 9, do contain fluoride, but if you want, you can always write non-fluoridated paste for your patients also. Main purpose of using the paste here is just using a very, very mild abrasive to wear off whatever plaque would have collected in the last 24 hours. So the whole idea here is till up to 4 to 5 years of age, you can even use the paste just once, especially before sleeping. You can insist the parent uses a paste at least during the night brushing, and eventually 5-6 years onwards, 4 to 5 years onwards, once the child is used to, he can spit as and when he wants, then of course we can use the paste more frequently. Idea being fluoridated paste should not be swallowed by the child. And one more thing, many times the company people or the brochure does mention, so we have to use a very small amount of the paste. Ideally, a smear of paste or easy to understand for small children up to 5 years, even half the size of a pea is sufficient. The idea is to just clean off the surface with a soft brush. I'll be also showing you the brushes. And as you can see, the brushes are available right from the ones which are available for cleaning the gums. I had showed you one finger brush also earlier, right up to 6 months to 36 months, 3 years to 8 years. Again, different companies offer different age groups, but you can just tell the parent whatever the size the child is comfortable in gripping the brush with. And the head of the brush, let me show in this slide, the head is here. The head of the brush in one go don't expect it to cover more than 1.5 tooth. That is the back tooth, because if it is covering more than 1.5 tooth, then probably the child will not be able to maneuver it. And still, I will stick to my idea that brushing at least once, and depending from child to child, should be thoroughly supervised, and if need be, the parent should insist on doing it once till they feel comfortable and confident that the child is able to do it himself or herself. So those I've tried to include some basic things, so that if at all somebody has some queries, please feel free to ask, and I'll try to answer it. If not now, maybe little later. Thank you so much. Thank you.
Thank you so much, Dr. Mandeep. Now I would like to request our chairpersons to give their 2 cents on the topic. This session was really very informative for all pediatricians. Over to you, Dr. Aggarwal, sir. Please enlighten us. Dr. Aggarwal.
Am I audible?
Yes, sir.
Thank you, Dr. Mandeep, for an excellent and highly informative talk on common problems of dentistry in children. You have nicely covered common dental problems of caries, malocclusions, bruxism, dental trauma, etc. in detail. And as everyone knows, the dental caries is the most commonest dental and public health problem in India with a high prevalence up to extent of 48 to 49%. Rightly said, every other child is suffering from dental caries. So, although dental problems are not life-threatening, but they cause a lot of morbidity and psychological stress. However, they can be prevented and controlled to a large extent by public education, motivation, and timely intervention. As rightly taught in medicine, before planning treatment for every disease, we must take a thorough history. And in the dentistry, we must know what is the brushing technique used for the family, history of thumb sucking, bruxism, or any a type of toothpaste, fluorinated or not fluorinated, or any history of hereditary dental problem in the family. It is the duty of the pediatrician, as rightly said by you and a family physician, to provide the right knowledge about the etiology and the methods of prevention of the oral dental problems to the patients and to the families. Exclusive breastfeeding should be promoted till 6 months of age, and afterwards bottle feeding, in between bottle feeding, and especially night bottle feeding should be strictly avoided. And this is a big source of night caries in the children. As you said, teeth should be brushed twice in a day, in the morning after breakfast and the night before going to bed. In addition, teeth should preferably brushed after eating any sweets or sticky food material. Use of fluoride toothpaste or fluoride containing mouth rinses should preferably used above 6 years of age. After meals, mouth should be rinsed with water and gum massaged with a finger, and dental floss should be introduced as an appropriate age. Since intake of sweets is directly related to the dental caries, it is recommended that total amount of sweets of the carbohydrate-rich fruit should be restricted. And since diet during pregnancy influences the formation of caries-resistant teeth, hence the diet counseling should also be given to the expectant mothers. With these few comments, I will hand over to Dr. Neetu for her further comments, and we have few questions from the chat box.
Thank you, Dr. Mandeep. It was really a wonderful session you had taken. You had wonderfully elaborated all the points in dental a kid suffers from and what all possible problems a child can have. And as Dr. Aggarwal, even he elaborated all the things. I think all the pediatricians must be enlightened now about all the dental problems which are associated in the growing years, so that they can look into that and refer the child to a dentist. So thank you, Dr. Virdi, for this session. And now I would request the panel, if there is any questions, Dr. Mandeep can answer for that.
Thank you, Dr. Aggarwal and Dr. Neetu. So there are some questions in the chat box, and I will quickly go through them. I request Dr. Virdi and the chairpersons to please tell the answers. First question is how to prevent stains over teeth. There are many patients on oral iron supplements, which could be the reason for staining of teeth. So what advice should we give to these patients?
Yeah, that's very, very, common thing which, yes, parents do complain of stains. We have to appreciate the point that generally the teeth is not the one which they directly get stained. It is the plaque, which is present on the teeth, which gets discolored with the iron. Of course, when a pediatrician recommends iron, the child needs iron, that needs to be given. Of course, the vehicle or the form in which it is given can be changed if possible. Rather than syrups, if tablets are given, and if the child is advised to crush it in the posterior teeth and take it in, the chance of developing stain is going to be less. But again, coming to my first point, it is the plaque which is going to get stained. So if the child is able to maintain the hygiene, of course, once the professional prophylaxis or cleaning will have to be done. And once a professional confirms and polishes the tooth to nice sheen, and eventually the parents are able to maintain that same level of plaque freeness, teeth to be free of plaque, then the chances of those stain developing is very less. Because you have to remember, these are all extrinsic stains. I'm sure you're talking about extrinsic stains only. So they can be, they can be prevented by just following these 2-3 steps. It is difficult, and many a times parents will not have the time to do it. And you can just imagine, if 2-3 days it is not done properly, plaque is going to be there again, it's going to be stained. So considering the concept of keeping the teeth plaque free, and of course trying alternative forms in which the medicine can be given, and sort of a combination of these things, asking the child, as Dr. Aggarwal very rightly mentioned, rinsing after each meal. All those things put together can be of a help. And of course, if the child is little bit bigger, bigger in the sense he's a little bit older, and he is in his control of his spitting thing, and he can spit on demand as and when required. If possible, there is a mouthwash which contains 3% peroxide, hydrogen peroxide. If it can be diluted to 1/3, and we need not give it to the child himself or herself, you can ask the parent to take a gauze piece, not a kerchief, it may not work. A gauze piece easily available at each chemist, all chemists. Just dip it in that diluted peroxide mouthwash, please. I'm talking about mouthwash, hydroxyl it is called, it's available on chemists. I'm not talking about commercial peroxide. Be very careful. And just wipe with it 2-3 days. Most likely your children who are taking iron will at least reduce their stains by 70 to 80%. They will still have it. And once they finish with their iron, or when they are not taking iron, then they can again go for a professional cleaning and probably maintain a good oral hygiene. That's what generally I do with my patients.
Thank you so much, sir. That's a really good tip, making the children clean their teeth. Parents can clean the teeth with mouthwash.
Peroxide mouthwash.
Peroxide.
Hydrogen peroxide. Generally, it's available in 3% concentration. But when you're using for small children, say 4 or 5 years, or 3.5 years onwards, you can dilute it to 1/3 and use it. So I'm looking at about 1.5% finally. So whatever is available to you, dilute it accordingly for your parents. Your patients, advise them accordingly.
And it comes with the name of hydroxyl mouthwash.
Hydroxyl, yes, very much.
So the next question is, the electric toothbrushes which are now available in the market, what is your opinion on them? Are they better than the normal toothbrushes, or you don't recommend them? What is your opinion on the electronic toothbrushes for children?
Ma'am, any brush is good than no brushing. Of course, normally there are 2 stages of efficient brushing. One stage is to take the brush where the teeth needs to be cleaned, and second stage is to do the correct motion of the teeth, which is going to clean the teeth. And scientifically, it has been proven that below 9 years, earlier it was 8 years, I am making it 9 from my side, so let it be 9. Below 9 years, the child may not have the dexterity to manipulate the brush in the mouth to clean the teeth properly, especially at the gum and the tooth margin. जो बड़ा बड़ा दांत का surface है वो तो clean हो जाएगा, जहाँ पे gum और tooth meet कर रहा है वो बहुत difficult है. So if a child properly under guidance, at least some training by the parent or the caretaker, uses a power brush, the size again should not be more than 1.5 of one tooth, preferably power brush में one tooth. And if they learn to place it in the right position, it is going to be more efficient. But again, bottom line remains, some form of brushing is better than no form of brushing. Only thing is, brushing is going to be helpful, and if done properly, totally prevent the caries. And if not done properly, will at least reduce the number of surface of caries. And of course, every time if the pediatrician, emphasize, I think the parents and children can take care of these things. I hope I've answered. If something is left uncovered, please you can ask again.
Thank you, sir. The next question is, do we need to clean the tongue during the first few months of life?
See, the thing is, whatever microflora is developing on the soft tissues that is developing. I will not answer this question directly. Okay. I will tell you the consequences, what's going to happen. Now, the thing what happens is, I'm answering purely from the concept of preventing dental caries and periodontitis or gingivitis. Forget periodontitis, gingivitis, which is the early stage of periodontitis. These are the two conditions which are thoroughly dependent on deficiency of oral hygiene in the oral cavity. Right. Now the thing is, once the teeth erupt, the microflora is gonna change towards microorganisms which are in tooth. And first of all, reduce the pH of the tooth. That is not the tooth, the plaque on the tooth, and that reduced pH is going to dissolve the inorganic content and then the organic content, and then the caries are going to happen. Same is true with gingival diseases. If you let the microflora to grow in the oral cavity, once the number is more, the type of microorganism which are going to be responsible for the disease are more, they are overpowering the helping of the healthy microorganism, the disease is going to develop. So cleaning of the tongue may be having two advantages. First of all, it is going to reduce the load of the microflora. Second of all, a very important thing which I initially said, that is, we are making the infant, as he is growing to his childhood, getting used to the idea, getting used to the taste, the feel of a clean mouth. Keep these things in your mind and make your decision. Very frankly, that is what is the correct technicality behind it. So, because I just don't want to say ki mat karo, ya karo. So I've just told you what are the sequences, what are the things which is going to happen. Of course, keeping it clean, you cannot perfectly keep it clean, because again, it is going to have all the microflora, all those deposits on it, but it's a good idea to clean. One more thing I did not mention in my presentation, probably because this question is asked and we're talking so much of microflora, generally I try to avoid going into details. The thing is, always remember, and I'm sure most of us are aware, if the mother, forget the mother, the caretaker, whoever is the caretaker or whoever is handling the child, it may be the sibling, it may be mother, father, maid, whomsoever, if he or she is having dental caries, if he or she is having gingival disease, the child is going to have the same transmission of microflora and is going to develop the same conditions unless and until special care about the hygiene and oral health is taken. I think with all these points, we will be able to guide our patients accordingly. So yes, majorly, yes, we clean them. Majorly, we can clean the tongue with gauze as and when we feel it's too whitish in appearance. And most of the times, that change in color happens when the child is under certain medication or things like that, less fluid intake, those things. So keep all those things in the consideration and then instruct accordingly.
All right.
Dr. Mandeep, two more questions because we are nearing 4 o'clock. When we
A
still
little
intervene,
louder. I am not. You're not very clear. You're audible, but not clear.
when you will intervene when permanent tooth has started appearing, but temporary tooth has not fallen.
Sir,
Am I
intervention
clear?
for what?
Audible?
Caries?
No,
No, no, for
sir
permanent
is
tooth
asking
has
that.
started appearing.
Please.
Sir is
Dr.
asking that permanent teeth have started coming, but the temporary teeth have not fallen. So when do we intervene?
Actually, these are again going into details, but I will try to explain it within 1 minute. See, sir, what is going to happen is we have two type of teeth: succedaneous teeth and the teeth which don't have precursors. So all our permanent molars are not having precursors. So this problem will not come in them. Typically, I'm sure you're talking about the lower anterior teeth. I'm sure you're talking about these because this is a very common situation where in the lower anterior teeth, you will see 2 rows of teeth. You will see the milk teeth, of course, and then you will see permanent teeth erupting behind them. If I'm not wrong, that is what you're saying about. So, sir, we have to understand. है ना, यही बोल रहे हैं ना आप? So this is this is a natural phenomena. I'll just go a little into details of it. Normally, by nature, the upper incisors, they are supposed to erupt a little bit labial of the milk teeth. Please, little attention if you give. The permanent anteriors, incisors, are supposed to erupt little bit labial to milk teeth, and the lower milk permanent teeth, the lower anteriors, incisors, they are supposed to erupt behind the milk teeth. So it's perfectly normal. Normally what will happen is they are angled like that the lower anteriors are going to erupt, and as soon as they erupt, they're gonna wear off the root, or resorb in our technical terms, the root of the primary tooth, and then those teeth are going to shed off. This is what happens in most of them. This is normal development. If something different than this happens, the position of the primary or the permanent teeth is little different from ideal, then probably you're going to see it for longer. Now, our idea is that lower anteriors should come, say, by 7th birthday, normally 6th birthday, but I like to give one more year, 7th birthday. So by 7th birthday, if almost 2/3 of the incisor is permanent, is erupted, and primary is still around, then you can always, and if the primary teeth is very firm and the patient is very, the caretaker is very apprehensive about the double layer of teeth, I think it is the time you may refer the child to a dentist, any dentist. It's a very simple procedure. In fact, if you have xylocaine around, you can also
we have
just apply some
and summarize it. You're saying that by 7th birthday, he should be referred, or child should be referred to a dentist after the 7th birthday if this problem persists.
If this problem is persistent. Otherwise, you have to educate the patient that this is normal. And of course, there is a lot of generic pictures available which can be shown to the parent, and they feel very sad. That's what generally I do. No, I did not include it.
Cover the rest of the questions that are there in the chat box, because there are quite a few questions. One is it okay if the child does not spit out toothpaste?
See, if it is a non-fluoridated toothpaste, I did initially mention that we are using very minimal paste. And very frankly, in such small children, paste is not the very important aspect. If you are apprehensive, if the parent is apprehensive, the child is not spitting, you can use minimal or don't use the paste. But the non-fluoridated paste generally is designed in a way, especially the 022 and 225, understanding, keeping in mind that the child may yet to spit. Basically, the paste will have some very mild abrasive and some form of sodium lauryl sulfate, which is nothing but soap. So yes, the child should not indulge in taking a lot of it in, but yes, a little bit if it goes in, it's not going to do much damage. Bottom line is use minimum as I've just told the quantity. That is what it is. And supervision.
Thank you, sir. Next question is, are there any devices for thumb sucking?
There are a lot of devices for thumb sucking, but when I teach management of sucking, I tell them the features.
So what is your take on use of pacifiers?
As remind, please come again.
What is your take
what I'm saying is,
I think there's something.
What I'm saying is, if we are using the device as a reminder, but always remember, you will pause.
I think
of the thumbs is basically segment, and if it is not resolved, just giving a appliance will not be of help. You will have to find the cause, then help the child with a appliance which is just a reminder.
Exactly. First, we have to take care of the behavioral aspect of it, and only then any devices.
Yes.
So what is
it's a reminder?
Yeah. So what is your take on use of pacifiers? Is it safe? Do you advise using pacifiers? And if yes, if a child is on pacifier, till what age should they be continued?
Again, for this question, I always answer technically. I don't say yes or no. I tell you what will happen. See, till 3 years, 3 or 3.5, 4 years, fourth birthday, if at all pacifier is having any deleterious effect on the growth of or shape development of the face, it will be taken care of once the child is able to leave by 3.5 or 4. But if it has become an habit and the child is still using it, it will be deleterious. And obviously, we all pediatricians understand having a pacifier means maintaining its hygiene, which is not easy. So I'm not for it. My child never had it. And whoever asks me, I for sure can say we can do without.
Pacifier
not
contains
helpful.
honey. It is the very precursor for dental caries. No?
Sir, can I just get that question again?
Like
Can I just
pacifier contains honey, and it is a precursor for
Of
dental
course,
caries.
sir. Any form of sugar. Dr. Aggarwal said it very well in a very technical language. Anything that sticks to your teeth, be it sugar, be it carbohydrate, be it whatsoever, anything. Just try to. We have to keep it clear in our mind. Anything which microorganism can change into acid is going to give caries. It's very simple. Longer. See, very small, very important thing I would like to say now that we are on this topic, because otherwise it's endless. Remember, quantity of sugar, very important. Frequency of sugar, very important. Duration, very important. So, if it is less sugar kept into the oral cavity for very long, it will cause caries. If it is very sticky, taken very frequently, it will cause caries. So always remember when you are advising the parent, the sticky food or the sugary food is to remain in the mouth for the minimum time. So as I think Dr. Aggarwal also mentioned, rinsing after the food or even after a treat of a candy or a sweet or a ice cream, it's a good idea and it will be really helpful. So sugar is damaging in any form, anyway. But of course, frequency, quantity, and duration is going to be the one which is going to be determining factor. If you give me half a minute more, I'll just try to explain a very simple concept of preventing caries. Caries will not happen if 3 to 4 things are not there. You would need a substrate like sugar or whatever. You will need a microorganism which is going to cause the fermentation. You would need a tooth surface and you will need time. इन चारों में से आप कोई भी एक चीज हटा दो, केरीज हो ही नहीं सकती. आप या तो माइक्रो ऑर्गेनिज्म हटा दो, आप या तो सबस्ट्रेट हटा दो, उसका टाइम कम कर दो, आप दांत के स्ट्रक्चर को ठीक कर दो. इनमें से चारों में से कोई एक चीज हटा दो, 0% caries for sure, है ना? So that I think this will really help you guide your patients.
Thank you so
Thank you.
much, Virdi sir and Aggarwal sir and Neetu ma'am. Today's session was in fact very informative. My take-home message from today's presentation is hygiene is extremely important, starting at infancy. The moment the first, even the cleaning of the gums is extremely important before teeth eruption. So first and foremost, we should ensure hygiene in all our children. Secondly, we should encourage brushing twice a day, starting at infancy. I think that's a very good message that sir gave. Indian parents especially don't understand the importance of brushing twice a day. Forget cleaning of the gums. So it's very important to maintain hygiene. Thank you so much for patiently answering so many questions of our audience. On behalf of BLK-Max Centre for Child Health and IAP Central Delhi Branch, I thank everyone who take out time to attend this session today. And we will be coming back next month with another interesting topic. With that, I'm Dr. Ritika Goel and I'm signing off today's meeting. Thank you so much for attending. Thank you.
Thank you.
Thank you.
Thank you.